Welcome back to Healthcare Rounds, your insider access to the healthcare industry. I'm your host, John Marchica, CEO of Darwin Research Group. Excited today, going to have a conversation with Dr. Trudy Hall, Chief Medical Officer for TidalHealth. And we've got a bunch of things to get into today. So without further ado, Dr. Hall, thanks for coming. And I thought maybe just to start off by giving us a little bit of your background, and then we'll get into TidalHealth.
Yes. Hi, John. So good to be able to have this conversation. And just to introduce myself, my name is Trudy Hall. I've been a practicing physician almost 30 years. Grew up in New York. That's where you hear a little bit of a New York accent. Did my undergrad school at St. John's University, then came to New Jersey to do my medical school at Robert Wood Johnson, University of Maryland, and Dentistry of New Jersey. Now the name's back to Rutgers, but Rutgers Medical School. And then did my training in physical medicine and rehabilitation. That's my specialty. Primarily was known for brain injury rehab when I practiced in Baltimore. And then for the last 16 years, have been in physician executive medicine and have held numerous positions, and currently I'm the Chief Medical Officer for TidalHealth, which is the new healthcare system that has been around now for 5 years and is servicing the patient on the eastern shore of Maryland, Delaware, and Virginia. So that's a little snippet of my history and my background, and just happy to elaborate on any of this. But I think having the background of physiatry or physical medicine has always been about team basis and how we improve care. And that has just lended to give me some of the tools of being a physician executive and looking at how we drive care for communities, which is my passion of the quality and the safety of care that we give to our communities.
You answered a question that I was going to ask you, which is what was driving that transition from being, a practicing physician in this specific area to wanting to be more of in an executive role and influencing care at the system level. And so, if you have anything to add to that, but I love a good story. So this is a good story. I've always been independent practice. I had a private practice in Baltimore and contracted with multiple hospitals. But I call myself a little bit of an independent bunny in medicine and providing care really at the clinic, and really starting and driving programs for hospitals, specifically around physical medicine and rehab. So my chief medical officer for the chronic hospital, I was the medical director for their brain injury and behavioral brain injury unit. I was an independent contractor, and literally told me he was leaving to go back to the main rehab hospital. And jokingly, I said to him, I really like you, who am I going to have to deal with now afterwards, And he literally said to me, he goes, well, why don't you do it? And I said, I'm an independent contractor. You got to be kidding me. And long story short, next week, the CEO pulled me in his office and he said, well, we spoke to the board and we all decided we want you to be chief medical officer. And I said, you do know I have a practice and another job that I do. Right.
And they said, you know what, just give us a couple of days. We'll work it in with your schedule.
I think if you're lucky enough and you get to a certain point in your career where the stars align and you get to do what you like to do and you feel like you're having the biggest impact, but just sometimes it takes a number of years to get there. I mean, I know, like with Darwin, I joke about this all the time. It's like, I get to talk to interesting people. I get to write. I get to analyze things and build things. Like, I get to do what I want. And I couldn't have said that 20 years ago, but just sort of like fell into where I am now. So we've both kind of gotten to that place, I guess, in your instance through another person. But we've managed to make it. So I wanted to talk a little bit about, well, first of all, the structure of TidalHealth as as a system is a little bit different because of where you provide care. So can you talk a little bit about Tidal? And then what the follow-up to that is what I really want to know is, or have a discussion around the Maryland payment system and how your system, your healthcare system, deals with all of these different incentives. But first, before we get to that, talk a little bit about TidalHealth and how you're organized and where you're providing care to patients.
Sure. So one of the interesting things about TidalHealth as a system, so the main hospital is a level 3 trauma center and a tertiary care center that actually started doing open heart surgeries in the 70s, which is really rare for, a community-based hospital to be doing that level of complexity of surgeries. So the last name is many hospitals and systems have names. So last it was Peninsula Regional Medical Center, PRMC. And then there's a small hospital, almost like a critical access hospital on the edge of the shore, in a little town called Crisfield.
In Maryland.
All in Maryland, Crisfield, Maryland. And if you go know Smith Island or Smith Island Cakes, it's like really on the edge of where Smith Island is. And that facility serviced a very small community, and there was a decision from the state to make that facility into what we call a freestanding medical center, which is primarily 24/7 emergency room. It felt that it needed to be part of a system because quite of those patients were being transported to Peninsula anyway for care. So there was a decision to actually put it under the umbrella of Peninsula. And then a community hospital in Sussex County, which actually is only 26 miles away from the two hospitals, but it is crossing a state line. So right across in Delaware, Community Hospital, Nanacoke Memorial actually needed to consolidate or merge with another healthcare. And then really all of that kind of came together as our primary, what I call healthcare delivery system, hospital-based or facility-based delivery system. And they came up with the name TidalHealth. Now, all the plans and everything was to be done. And they actually became a system at the absolute worst time, which is right in the middle of the pandemic. Which they already, well, actually it helped because being part of a system in the pandemic actually allowed both of those other facilities to be able to navigate some of the challenges that they would have had if they would have been, small systems on their own, which a lot of it was, resources, which was supply chain resources, protective equipment, and then even the resources of labor and expertise to be able to navigate and ability to transfer patients to a higher level of care if needed. So it went through that transition for being a system. And I was happy that I'm here now about a little over 2 years. They did need a chief medical officer to really look over at their system and be able to look and see what we need to do regarding clinical integration, medical staff development, developing a quality and safety infrastructure for the system. So TidalHealth is a chassis of those three main facilities. But on top of that, we have, I think the last number is 380 physicians that we have employed, 26 specialties. I think over 45 outpatient offices and clinics, and joint ventures with a lot of other healthcare facilities like home health, DME, surgery centers. So really, if you were to look at an integrated system with a strong population health component, Tidal Health has that ability to do that. And I laughed about this. I didn't even know there was such a thing as Western Shore and Eastern Shore. I mean, we all know about the Eastern Shore because you cross over that like 5 Mile Bay Bridge. But everybody kept telling me about the Western Shore. And I'm like, where are they talking about? So just to know everything on the other side of the Bay Bridge, like Annapolis and DC and Bowie and Columbia and Baltimore, that was all considered the Western Shore. So kind of very interesting, this whole Eastern Shore and Western Shore. So what is nice is, healthcare has pushed over the last really 10 to 15 years about looking at the total cost of care and then looking at the hospitals having to go outside of their walls to participate and to have to manage the integration of care. Because only when you look at healthcare dollars and spend, only 20% of it's actually hospital. A lot of it is outpatient, ambulatory medications, and even patients' lifestyle contribute more to their health status than really, a 4 or 5 day hospital stay. So,
well, what's amazing to me is how quickly, especially in the midst of COVID, coming together in the middle of a pandemic. I mean, I remember, actually, I think it may have been on a podcast interview with Neil Meltzer from LifeBridge talking about that they were building their own sort of PPE manufacturing facility. Did you get in on that at the time? Was there any shared help, or was it more of a competitive situation with LifeBridge and Hopkins and all the rest?
So John, you probably don't know this, but I was the COVID facility czar for the state of Maryland.
No.
So yes, I was. So I oversaw a community hospital, and it was a 40-acre campus in Laurel, Maryland. And I had just shut down 140 beds, an acute care hospital, behavioral health, and ICU, rehab. Literally had just closed the beds down, and we were building a new freestanding medical facility. And we had just merged with University of Maryland. So got the call from Governor Hogan. I need for you to open back up that hospital in 30 days.
Oh my gosh.
Yeah. And so anyway, I was the executive over Laurel 345 COVID Hospital for the state of Maryland, which was 145 beds, including a behavioral health unit for 2 years. And pretty much ran that entire hospital with 100% contract staff from all over the country. So I'm not joking when I say COVID czar, because I got probably called for almost any complex case in Maryland, and we had to take them. So we developed really integrated systems of really transferring patients across the state, being able to accept them as well as transfer them back to their facilities. And the state of Maryland, really opened up their checkbook to pay for it and to support. What that did is that gave relief to some of the hospitals. I mean, we had to do all kinds of stuff. We were popping up trailers and, having to do all kind of negotiation for PPE, but we at least had a facility where we had beds. If a hospital system couldn't care for them, that we would take them. And my team was phenomenal. I mean, the lives we saved was just. I mean, when I look at things I'm most proud of, I would probably say that's one of the things my husband and my daughter put up with me during those 2 years. But calls all hours of the night, at all times of the day. But but it was we all had to lean in and do what we needed to do to save lives. So again, and I laugh because I think after doing that, I woke up one morning and literally said to my husband, "Okay, I need something else," So and then this opportunity came up, which was exciting to me because just being coming from a system within a system, that was what exciting to me, to work with a healthcare system that's servicing a diverse community. So that was good.
Well, I will say, a lot of negative things with COVID, a lot of things that we could talk about, failures at all levels of government and all that. But what I say is, what kind of like keeps me optimistic is all of these amazing stories, all of these incredible stories of healthcare systems. I mean, I remember at the time, my wife, who's a nurse, she was at Dignity downtown in Phoenix, and Dignity, and had to stand up a telehealth program in like a weekend. And that wasn't even unique. Like I've talked to other people who said they had to do some similar things, but for her, she's like, I'm not a technology person. I don't know how to do any of this. But people coming together, these healthcare providers and just really smart, dedicated people who just want to do good. There are some amazing things that were happening despite all of the, let's face it, the terribleness of the pandemic.
Yeah, I joked around and say it brought out the best and also the worst in us. So
Yeah,
it really did. It really
it's
did.
true.
But I mean, I always say through adversity, stones shine through, and I think really, some of the stones of what some people did was just amazing, and their sacrifice. People don't realize, that was a moment of sacrifice. We didn't have all the answers, but everyone did the best that they can with what they had. I mean, I had to learn. I had to learn a whole bunch of stuff. I'm a physician. I used to just joke around and say I'm a physician, but I had to learn facilities and air pressure and a whole bunch of workflows and a whole bunch of stuff. But I will say University of Maryland did lean in with a really expertise team and a project management team. And we got everything done, even including implementing a EMR system within those walls. So it was remarkable. And I will knock wood, would not want to ever go through something like that again. But at least some of us now have a little bit of a playbook of what to do and what not to do. So
Yeah. So briefly, what is it about the Maryland system that's different than the way we pay for healthcare elsewhere? And then, and the follow-up to that is, what's it like to be working in different payment systems within the same IDN?
Yeah. So I always joke around and say, I know Maryland like the back of my hand. I said, I do not know Delaware, but I'm having to learn it quickly. So just some history, because I think a lot of people don't know about the payment system of Maryland and why it's different than every other state. So go back 1977, Medicare and Medicaid, federal government wanted to see if there was a way to control some of healthcare cost. And they did really kind of an experiment with 5 states. So out of the 5 states, and I remember which ones they were, but literally Maryland was the only one that kind of figured it out and continued with what we call a health service and cost review commission. Consists of, I think it's 8 commissioners, usually appointed by the governor. The entity has executive director, has a lot of statisticians, have legal. I mean, there's literally a team and staff that actually collects and processes the information so that some decisions can be made. And it is a collaboration between really the state, industry, our healthcare facilities, and then also the payers. And then we do have the Maryland Health Administration, MHA, that's also a mediator and in all of these discussions. So there's positives to the system and there's some negatives to the system. And that is, if you think about how you pay for services, I usually like to describe it as a capitated rate. So in other words, I'm going to give you, $1 million to take care of these, and we'll say, 500 patients, and you have to stay within that range to be able to care for them. Now, the good thing is if you're able to do it well and you're effective or efficient, then you have the ability to maybe retain some of those funds to do other things to impact care. But if you have increased volume, right? And even though they do calculations every year, every couple of years, and they have a way for you to apply for a change, it's just not the same as the fee for service that's being done, in every other state, which is, more what patients you care for, whatever you bill for, that's what you get paid for. So it's a little bit, that's the difference. I'd like to say, you get capitated, this is how much you get paid, versus a fee for service model in which you're able to do what you need to get done. So so my history with the commission was I was in a leadership position with one of the medical societies in Baltimore, and my predecessor was also a physician, female physician, who was she came from my same organization, which is the National Medical Association. So when she was finishing up her term, it's a 4-year term. When she was finishing up her term, she had recommended that I follow her to do the term. Little did I know what I was getting into when I said the word yes, but but it was interesting because I think I was able to be that clinical voice because I was the only practicing physician that was on that commission. We had one or two physicians, one in policy and one on the payer side, but literally we had, hospital administration and, other industry that was on that commission. But I think as a clinical voice, really every decision that was made, what was going to be the impact to the community, and that had to be the voice that was in the back of the why. Why are we doing this? Why are we making this decision? And the responsibility of that commission to protect and provide quality services for the community. So that was an interesting journey. I actually served two terms, and I actually chaired the beginning of the quality-based reimbursement system from Maryland, because we did have the unique opportunity to make some tweaks to that program and not follow the one that was done, by the government for the rest of the country. So I did start that journey. I'm not responsible for what it is now, but I did start that journey for that quality-based reimbursement program. So that's been my history, and that's just a quick snapshot from my lens of the HSCRC.
So follow-up question to that is, where are we with that quality reimbursement program today? But also, it's kind of like the bigger question that I wanted to ask, which is not on my sheet here. But given your expertise and your experience in this area, the knock on managed care of the 80s and 90s, way back when, was, we're going to do these capitated arrangements. We're just not going to. We're going to deny access. We're going to deny care at every turn, and that's how we're going to make money, which, of course, kind of led to where we came in the 2000s and then the next decade, and kind of where we are today, where we're more triple aim focused, let's say. But when you're under this kind of global payment system or statewide payment system, like a capitated system, what has been, for organizations like Tidal, what has been the drive beyond this capitation or beyond denying services? How do you provide that higher quality care when you're constrained in the way that you are within the system?
You have to be so efficient, and you have to have a process improvement framework and infrastructure. That's how you do it. I mean, we have probably the shortest length of stay in the state, probably the quickest turnaround of our ED, even being, in a rural area. Our resources, we're locked into some of our resources. Everyone's having to kind of struggle for labor, whether it's nursing or nowadays, even something as simple as an echo tech, and, radiology technologists, which you would never think that we would have shortages of those kinds of fields. So part of that is really looking at how do you provide this level of care? How do you be very efficient? How do you have checks and balances? How do you have that infrastructure to be able to first of all get there? And I always talk about maintenance, to maintain yourself to be there. And then how do you translate that and be fluid enough to figure out as a system, how do you actually have the nuances between the two states in what you do? So for instance, our readmission reduction program in Maryland is a little different than really the readmission reduction program in Delaware, right? In Delaware, maybe looking at some more specific disease states. And then even like when you look at age caps and preventable, avoidable utilization from the ED, we have all these acronyms and all these programs, but there's like different nuances of them between the two states that you have to be able to have system leaders to be able to direct their teams to be able to address, if that makes sense.
So when you talk about nuances, is that just in terms of how specific incentives are set up? Because obviously, you're in a tight region. I can't believe that the healthcare needs are, I'm sure they're different, but are tremendously different, especially if you're talking about, cutting down on readmissions, for instance. Is it that you just have to pay attention to the nuances in those incentive structures in the different states as a CMO for a health system crossing these two states?
You need to look at the nuances of your community. So we have Peninsula with, I would say, probably a 40% minority community, about 30% African American, a significantly rising immigrant Haitian Creole community, right? We have the chicken farms and we have the migrant farmers that are here. So we have this community, and Hispanic speaking probably being the other 10%. So we have a population that we have to do a good or better job of communication and language-based care to be able to impact the outcomes, as well as looking at our data to be able to figure out what do we need to do for those programs and those people and for different populations of people that actually have specific needs. I'll give you one example. We were getting some data that we were having increase in OB delivery C-section infections. When we looked at it, we found that we saw a higher rate in our African American community. Well, did we have a language sensitive discharge information, for that community? Did we have pictures, maybe that could address maybe a community that may only have a fourth grade, reading level, and then what was our follow-up systems that we have? Did we have community health workers that was able to go to the home and be able to double check and, check on things? So we made some changes. We created Haitian Creole communication, education. We did things in pictures. I'm telling you, within 1 month, we saw the rate drop.
Wow.
1 month. So, but then compare that to my Sussex hospital in Delaware, which is one of the most rising population on the East Coast. Why? Number one is Delaware, low taxes. And then they are popping up these 55 and older communities in Sussex that, transplants from New York, Philadelphia, New Jersey, that are all coming to Delaware. So you're looking at probably a higher income and a higher education level, and maybe different problems, right? So maybe problems that are more that you see in ages 55 and over with orthopedic, cancer, diabetes, cardiovascular disease. So you look at these two populations, and then you figure out from your population health model, how do you address this community in their healthcare needs, as they are really what I call like that transitioning health community, because a lot of them are transitioning. Some of them are still going back to those states to get their health care. How do you actually work with them to participate in your health care and create a new medical home for them, so that way you can totally manage their care versus things being done out of state, which actually impacts your in-state information. And the data is very important. Maryland, we have this very unique, robust database called CRISP that actually, that data actually helps to with the utilization of care and also with the efficiency of care. Delaware has a system not as robust, but if you think about it, you may not be having data that pumps into those systems that really give you information about the patient and regarding the efficiency and utilization of their care. So that's a little bit of the nuances of the differences between the states, and then also dealing with different, patient populations that you have to care for. So,
well, that's actually a perfect segue into health equity, I think, in pop health. And I wanted you to clarify something, because I feel like DEI, health equity, these are terms, they're really coming to the forefront, let's say, even since COVID. But the way I want to get some definitions out of the way. So the way that I think of like blanket DEI initiatives, they're more internally focused and they're more about sort of corporate. Is there access to jobs, it's more generic to diversity and equity issues within the organization. And then when you're talking about health equity, it's really more focused on health and external to the organization and certain populations or groups of people that, for instance, the one that everybody talks about or, widely known is that COVID really highlighted some disparities among African-American populations and other populations that we knew about, but boy, did it make it obvious in terms of access to treatment, death rates. I mean, so am I getting that right in terms of thinking about these terms, or am I getting it wrong? I want to get your sense of how you think about DEI, how you think about health equity, not some, healthcare researcher in Scottsdale.
No, that's okay. So, a lot of this, let's go into history. So a lot of this started when the Institute of Medicine did the unequal treatment report, right? And that was from the Institute of Medicine that showed that there was disparities in healthcare. So when you look at certain disease conditions nationally and even within our own state of Maryland, when you look at, the disparities of, how a Caucasian community may be treated or diagnosed or given access to, diabetes or, dialysis or, management of hypertension or cardiovascular disease. There were disparities between populations. And that just started us all asking, how do we understand this? Are there implicit biases in how we look and manage patients and patient populations? What is our education structure and infrastructure to be able to work through these biases to decrease the gap? So a lot of it had to be able, what were some of the educational, social, environmental structures that actually contributed to this disparities in healthcare. And that's when we started with really some legislation to be able to develop the infrastructure for us to, at least at a minimum, to start off with education and also start off with some research for us to understand, because you can't fix a problem if you don't know why. But what I can tell you is it's costing the taxpayers and our government a lot of money for these disparities. When you have certain populations that are diagnosed later stage of disease, when you have certain disease that are not treated, that may require chronic management. I say every dialysis patient costs about $65,000 a month to be able to sustain on dialysis. So when you look at all of this, it's just that we have systems in place that actually create a gap of how we provide equal care, equal treatment. Health equity really looks at it from what are the other drivers of the inequity in healthcare. And in health equity, took it a little bit different from disparities, which was kind of more race or cultural based, to really what are other factors of why patients may not get the same treatment or there's inequity. So I just lectured to a room of 200 college students at SU and UMES about this last week. Oh, I loved it. It was a sea of 200 students, all looking green and bushy eyed. But I started to but I started to talk to them because, there are our healthcare providers of the future, right? Respiratory therapists, social workers, therapists, nurses. They are our healthcare providers of the future. And part of them, we spend so much time teaching the new teaching the practice of our field or the specifics of the treatments. But a lot of times that soft piece of how do we treat all patients the same, no matter how much money they make, no matter their sexual orientation, no matter their culture or language, or so it kind of just broadened it. So that's when we look at diversity, equity, and inclusion. It's really giving a sense of belonging to the community. So it's not just for internally, because you want diversity, equity, inclusion for your team, right? Because a diverse and sensitive team, and educating them on what are some of the things that may not make all patients get equal care, right? So you look at that, but it also extends beyond, because you have to look and see what systems you have in place to address any disparities of care that you have. And a lot of it has to do with data. You should have your data on, and that's what we did for last year for TidalHealth. We made it as a strategic initiative that we wanted every single service or service line to pull your data to see if you had data that shows that there may be a disparity. And it's not just about race. It's also about poverty and all those other things that we talked about that may actually have a patient get different treatment or have a different healthcare outcome. So hopefully that made you understand a little bit. So I'm gonna give you the example that I gave to the students. I said, okay, how many of you have an Apple phone? And they said, all the happy Apple, users raised their phone. And I said, well, how many of you have an Android? The Android people kind of went up like this. And then how many have others? Because they got these other phones out there. There was like just a couple of them that went out there that had others. And I said, equity is if you pick up that phone and you dial 911, you'll be transferred to the police no matter what phone you have. I said, that is equity.
That's powerful. That's a really powerful way of thinking about it.
It just came to my head because, with kids, you got to deal with analogies, right? Some things that they can understand, and they all can understand their phone, right? Because they all live on it. Of course. So that was really my example of really trying to say, the responsibility that we have in healthcare to make sure there's equal access, there's equal resources, there's equal treatment, and then we also figure out what we need to do to eliminate or decrease any form of biases, implicit or not. So,
where I struggle with this, literally, I'm just thinking about this now, is that what you're talking, like the broader picture of what you're talking about, it almost feels like a collective action problem, and that it's a problem at the highest levels of government, whether it's state government or, to look at issues of access as sort of being, a constitutional right. And I'm not a lawyer, so maybe I didn't use that word the right way, but a right that is to be protected or something that is focused on by the government. And at the same time, these kinds of initiatives that you're talking about are really being undertaken at the private level, at the, systems like TidalHealth or, LifeBridge or Hopkins or other places that might have their view of health equity and how to address these kinds of issues. So I don't know. I mean, I just think it kind of feels like it's something that maybe should be addressed at more of a national level, but at the same time, it is the dominant. So health equity is when I'm interviewing healthcare executives, at least over the last, say, year to 18 months, it always comes up at top strategic priority. It's one of the most common things that I hear health leaders tell me is the focus of their health system is on. So I don't know. Have you thought about that? Sort of like the role. I'm sure you've thought about it.
Yeah,
But
of
what is
course.
the role of government versus the role of private institutions?
Yeah. So when Joint Commission, Joint Commission is the body that accredits hospitals. In other words, you have to have a Joint Commission stamp of approval for you to get paid
Right.
by Medicare and Medicaid. So when Joint Commission, last year came out that every hospital, a new requirement was that every hospital have to screen for social determinants of health and have to have an initiative to address it. So last summer, Nanacoke, our Delaware hospital, did have our survey. And what our team did underneath our population health team, they had the case management screening for the social determinants of health. And they chose food insecurity as one of the focused areas to address. So they screened all of the residents, all of the community that came into the ED for food insecurity. Identify which ones had food insecurity, especially being in a rural area where there may be decreased access. You would think they would have enough produce with all the farms around, but decreased access to produce and healthy foods. And then link them up to resources, link them up to food banks, food pantry, Meals on Wheels. And then close the loop to make sure that the residents did get those resources. And then this year, they're taking it one step further in having and ensuring that the food pantries have culturally sensitive food, because, taking someone from Haiti and giving them, mac and cheese in a box, or so,
Right.
it's just, that's not the food that they eat. So looking at, how do you actually have the foods that they eat to be able to have them to have access. And let's all admit the American diet is probably the worst in regarding calorie processed,
Yeah.
all the other stuff. So, some of the things, unless it's fresh fruits and vegetables, are not the best. So if you think about it, so Joint Commission is now requiring this, really. And a lot of times once Joint Commission requires something and they can either hit you a penalty or non-compliance, people start to pay attention. What Joint Commission told us was that we were probably the second organization since the beginning of the year that they felt got it right and understood it. They said that the biggest thing is a lot of organizations, they haven't wrapped their head around what to do with it. And some of them are not asking for outside help to be able to do that. So they did take our recommendation as best practice, which was great. And then state of Maryland, back to the HSCRC and quality-based reimbursement, they
Right.
actually added one of the measures under quality-based reimbursement, which was to look at health equity, which was the timely follow-up. So they have like 6 chronic disease conditions, and they have you can get a penalty if you do not have them to have timely follow-up, some 7 days, 14 days, and 30 days. They added a race-based measure to that to see whether or not there was any disparities in that timely follow-up based on, I think pretty much sure is race and one other measure that they actually are measuring. And then they also looked at the ED throughput measures. Are in readmissions, where are there any disparities in readmissions based on race? So now that's pushing, at least for the state of Maryland, like all the Maryland hospitals, we got to collect that data. And then once you have that data, then you have that data that either can drive guidelines, policies, and practice. And that's really the direction. So from the federal government standpoint, the social determinants of health, it's what is going on socially with patients, looking at the patients that we have that are immigrating. Do they have support? Looking at, what are our support systems for different healthcare entities and communities. And a lot of this equity is based on, some of the economics of our communities. How many of them are educated? What's the average wage rate? We have something called the ALICE score, which we measure in Maryland and in Delaware, which actually describes, communities that are living from paycheck to paycheck. And just really, how many communities do you have like that? And then how many single head of the household communities that you have, and how secure they are financially. that impacts their health. That impacts what they can do, what they can buy, where they can go, as well as, social and other support systems that they would have in place to help them to live a health and fruitful life.
Well, I think in some way, I kind of answered my own question and with your response, and that is, it almost feels like for the government to have yet even more say in this, you'd have to be under some form of single payer system, right? I mean, the way that they can influence through CMS or through external through like Joint Commission or things like that can encourage people to do certain things, but it really feels like maybe there has to be even more of a change to the system if you wanted that. But maybe we don't even want that national push in this area. To your point, if it's an issue of local populations, what's happening in Delaware, for instance, in that unit, in that hospital around that area, and the example that you gave of the maybe more well-to-do people that are older coming in, and maybe their second homes. It's like a cottage or something on the water, right? And that's way different than the residents there that might be in and around the hospital that have different socioeconomic issues. But the thing for me that always what you said that really hits home is it's not only identifying, but what to do about it, and having that sort of game plan to address these kinds of disparities. Because a lot of times, I remember one of the first podcasts I did was with a physician chief executive out of Florida that said, and when I asked him about these are you tracking social determinants and all these things in the EHR? And he said, I don't want to have to track something that I can't fix. As doctors, we like to fix things, and I don't want to ask questions and fill out this whole panel of things on this person if I can't make a difference. If we don't have a solution to that problem, all we're doing is acknowledging that the problem exists. And being a doctor, that frustrates me that I can't fix the problem, or I don't have access to whatever tools to be able to fix that problem.
Yeah, and I always make this joke about we can't cure world hunger, but we can give one meal at a time.
That's right.
Yeah, so part of this is being able to control what you can control, and really having community-based stakeholder resources and help. So, for instance, we found a tool called Find Help. It's actually a catchy name, but it is Find Help. So what our case managers do is when we actually do those social determinants of health screening, we actually have like almost 24 public and private entities that we can refer that patient to be able to get the resources. Now, that's only as good as the patient accepting and following up on some of these resources, but at least it doesn't give as much as a helpless feeling. Now, housing is probably the biggest one we can't do anything about, but there are some of the other social determinants of health that maybe we could help, and there are some community resources, some more than others, that will be able to make a difference. The other thing that, before we run out of time, that I think everybody should be aware of is this AHEAD model. So the AHEAD model is pretty much Medicare and Medicaid is looking for this advancing all-payer health equity approach and development of AHEAD model. But they're really looking at the whole total cost of care. I think a lot of the states are they're choosing whether or not to adapt that model. It's not the HSCRC model. I don't have all the details about it, but I think everyone should be following this model, because this model is looking at the ability to change the payer system of how services are being paid, not only at the hospital, but even across the total cost of care. So I'm going to say, and that's a whole show you can dedicate to the HEAD model. And I will say I am not the expert on it, but Maryland is making a decision to go ahead with the HEAD model on top of the HSCRC model. So I have no idea what that's going to look like. And then I have the state of Delaware, with a bunch of legislators thought that they should be more in the management of hospitals, and they did this legislation to create this commission to take a look at things. And I don't know, they think hospitals are pouring in money, but hospitals, a lot of them have closed, canceled, or consolidated since the pandemic due to labor costs and the inability to manage labor. And the rising cost of labor that has really been on the backbone of a lot of facilities. So that's just the future of where things are going. I think we'll find out probably by the end of the year of all the states that are signing up to this AHEAD pilot project. I don't know if it's a pilot, but I think it is a project that they're doing. And to see the impact. I always have a problem with front end decisions that has tail end consequences that we don't know about. And that's what happens when we do this, because even just to manage Medicare, like a lot of our seniors are jumping into this managed Medicare, and they don't understand, straight Medicare. You have to get authorization for stuff. Now you have something that your doctor has to get authorization for, or they can say yes or no of the care you get, or where you go for nursing home care or for rehab care. The devils are in the details. And unfortunately, some the community doesn't, they promise you a lot of stuff, but they don't understand what it could mean for your all of your care. And in some instances, it may not be what's best for you. So this is just a lot. Again, in front end, it looks great. We get support for this. You don't have to pay the 20%, and you get transportation. I mean, a lot of stuff. But if you have certain things that happen, it actually could matter what your insurance is. And again, those front end decisions and not understanding always the tail end consequences is what we always have to be careful in healthcare.
Well, there's always trade-offs, right? I mean, we have the system that we do. There's good in it, not so good in it, but it's a private-public partnership, for lack of a better term. And there are going to be, when you have this sort of managed Medicare and people bidding on contracts, and in this contract, we're going to give you this, or we're going to give patients this, we're not going to give them that. But the theory is, with all of these competitors vying for the patient lives, that hopefully the cream will rise to the top. Doesn't always happen that way, right?
Oh no.
But at some level, trying to understand these disparities and correct them. Good job security for you, and good job security for me as a services researcher. So,
absolutely,
Dr. Hall, it's been a pleasure. We've gone a little bit over. I could talk to you for another hour about this stuff, and I hope that you'll put some time between this one and the next one, but that you'll come back in the future and let us know how things are going at TidalHealth.
Absolutely, John. This was fun. I appreciate your invitation.
Thank you so much.
Take care.
And that'll do it for another episode of Healthcare Rounds. Our guest today has been Dr. Trudy Hall, Chief Medical Officer of TidalHealth. And as always, I'm John Marchica, CEO of Darwin Research Group. I haven't changed my name. I haven't changed my job, so I'm still doing that. Listen, do us a favor. If you like what you heard, please just go ahead and rate wherever you are, Apple Podcasts or Spotify. And please make sure to follow Healthcare Rounds on LinkedIn. So thanks again, Dr. Hall, and we'll see you next round.
Take care.